Good evening and welcome to Viewpoint. A further 8,000 doses of the Pfizer vaccine were delivered to Gibraltar this weekend by the Royal Air Force. It was the third consignment of the vaccine, with the Government of Gibraltar thanking the RAF Gibraltar, MOD Gibraltar, the Convent, the UK Foreign Secretary and all those who had made the delivery possible. Health Minister Samantha Sacramento immediately confirmed that the GHA would administer the second dose of the vaccine to those who had the first dose 21 days earlier. 400 GHA frontliners, ERS carers and residents were the first to receive their second jab, followed by individuals in the highest risk age category. The Chief Minister said he expected the 4 most at-risk categories and the frontliners to have their second doses in the first and second weeks of February. The vaccination programme is called Operation Freedom because it's hoped it'll bring about a fall in the number of Covid-19 cases and resulting hospital admissions, and in so doing, help restore some normality for Gibraltar. Viewpoint takes an in-depth look at Operation Freedom tonight, speaking to the Health Minister, the Medical Director, the Director for Public Health, and also the Director of Nursing and Ambulance Services.
I think everyone's feeling extremely positive. If you think about it, we started the vaccination programme on the 10th of January, and I think that the progress that we've made since then has been remarkable. The vaccines arrived on the 9th of January, they arrived that night, and there was no time to be wasted, and we started vaccinating the following day. First thing in the morning, we started with frontline clinical staff at the GHA, and in tandem, we also started the vaccination programme at ERS for residents and ERS staff. To look back now and think that since then, since we started, and that by tonight we will have administered just over 17,000 doses of the Pfizer vaccine, I think is truly amazing. And not a single dose has been wasted, even until today. It's been through the skill and hard work of our nursing staff that they actually extract 6 doses of the Pfizer vaccine without obviously compromising the vaccine itself, but that is because of the way that they do it so carefully, and they're able to extract 6 doses, which means that we've been able to have even more doses than when we initially planned for this and what we initially envisaged.
For everyone, I think, actually, the whole community, it's been a long, very drawn out process, but we have a glimmer of hope. So I think that little bit of optimism is driving everybody on now. The vaccine programme is doing so incredibly well, covering some great numbers of people, and I think that is giving us that little light at the end of the tunnel. So certainly from the clinical staff, we're seeing our numbers settle, and I think that is a product of the recent social lockdown, people becoming more acutely aware, because we've had a very difficult time with lots of people passing, which has been really very difficult, and I think that's focused people's minds a lot. And then with the vaccination programme, numbers are settling, and I just feel, it may sound a little bit premature to say, but I think we're just feeling like things are progressing in the right direction, finally, long awaited.
So we've had a whole year of fear, uncertainty, doubt. We've had wave after wave of infection coming in. We've just experienced our worst surge of infections, and we've had numerous deaths, dozens and dozens of a whole generation taken out. What we do know is that when this vaccine has been administered, what seems to be accumulating in terms of evidence is that if you do fall ill, you won't need hospital care. In other words, you may still catch the virus, but you won't catch the virus in a way that you're seriously ill. That seems to be the emerging evidence for all the vaccines so far. So that in itself is a game changer. It means that one of the reasons we had for lockdown is not just the surge in cases, but the overwhelming of our healthcare system. All of us need healthcare at some point in our lives. Some of that can be avoidable, trauma as a result of a car accident. Some of it's unavoidable, things like cancer or heart attack, though I would argue that you could prevent heart attacks if you chose the right lifestyle. So getting a vaccine means that we remove some of that uncertainty and some of that fear. What it doesn't do is it removes the chances of you getting infected. The analogy that I would use is a seatbelt in a car. What vaccines do is they provide a seatbelt. Mm-hmm. In this particular scenario, the car crash, if you like, is what we're trying to prevent. The car crash is getting infected. Mm-hmm. So the vaccine, just like a seatbelt, doesn't stop you getting an accident, but it means you walk away from it. Mm-hmm. And that, in essence, is what we're trying to do with vaccination, to protect those precious lives, some of whom we've lost.
At this moment in time, do you know roughly what percentage of ERS and GHA staff have had their second vaccine?
I think that the majority of the ERS staff, for sure, have received their second vaccine, of the ones who can, because of course we're still catching up on people who couldn't have their first dose at the same time. And I think that
because they were positive or had had COVID recently?
If they were positive at the time that we were doing the first doses, then they won't have been able to have done it at the same time as their colleagues, because we have less members of staff in ERS than we were able to do them in the first few days. We were able to do it quite quickly. Some of them may not have been able to have done it in the first week of the vaccination program. They will have had it at a later stage, which means that it's still not yet 21 days from when they had their first dose. Similarly, in terms of GHA staff, if you recall, we had a high percentage of people who were positive with COVID, so they weren't able to have it in the first time round. So anyone who wasn't able to have their vaccine in the first week because they were positive won't have been able to have their second dose this week. But we're making a lot of progress in relation to frontline staff. We have, as you know, we have 3 vaccination centres. We have a vaccination centre purely for ERS residents and staff, for infection control purposes. We have a vaccination centre in St Bernard's Hospital, and that's for the frontline staff. And then we have the public vaccination centre at the former PCC, at the ICC, and that's for all the members of the public who, as you know, we vaccinated people, almost everyone over the age of 60 by now, and people with clinical vulnerabilities as well.
Operation Freedom, it's a great name. It's designed really to try and get us back to some semblance of normality, something back to the way we should live and the way we like to live, and the way actually we are made as human beings, as social people who like to greet each other and shake hands and hug and kiss and do all of those very, very simple things which seem totally innocuous and harmless, but actually at the moment unfortunately have a big impact.
So you mentioned numbers. How many people have already been vaccinated, and how many of those are first doses and how many are second?
Yes, so the numbers have really moved on and do on a daily basis. At the moment, total doses as of the end of yesterday, 15,391. So that's an enormous amount in three and a half weeks, just under. Of those, 13,071 are first doses, and then within that, 2,320 are second doses. So total doses given are the 15,000 and then broken down like that.
And what percentage of, how many vaccinations are we expecting to have to administer in total?
Well, I mean, it's a very good question. So what we're doing is we're working on this priority list. Everybody now, I think, is very familiar with the priority list. Many people have registered online, and we use something called the JCVI, which is the Joint Committee of Vaccinations and Immunisations Guidance from the UK. Essentially, it's a kind of reverse cascade. So we start with the most senior, but we also make some caveats and priorities for those who are more vulnerable, those who have immunosuppression, those who have particular medical conditions, and of course we also take into account people who may be younger but work in frontline or work in a place where they may mix with lots of people and potentially be a carrier. So we work down into those categories, and in terms of the numbers, we will just work through those as best we can. The interesting thing about that is that even if we can't predict how many first and second doses we will give overall, or how many people within our population actually say, I want it and will accept to have it. As with each category and each priority that we go down, we are covering the more vulnerable, the ones who are at higher risk. So as time passes on every single day that we cover the priorities and vaccinate people, the risk to the general community and the risk to the people who are unvaccinated essentially becomes less. Mm-hmm. So we all talk about this magic figure with any vaccine of sort of 70% and above, this thing we call herd immunity. So namely, if you can vaccinate more than 70% of a population, it means that the transmission of the virus has so few people left, or the virus has so few people left, it's very difficult for it to be transmitted into a community, because almost 3/4 in fact, are immune or protected. So of course clearly that's where we'd like to aim, but we must also take into account that people are entirely within their rights to essentially want to wait or decline the vaccine, and some people just may not just come up on the radar or may not register. So as long as we can target those most at risk, and the whole campaign when we started with this pandemic a year ago was to protect those most at risk. So of course those are the people we're protecting best.
So the research that the JCVI, which is a Joint Committee on Vaccination and Immunisation, that's a advisory body that the government in the UK is obliged to follow, has reanalysed the data for the Pfizer vaccine. They also analysed the data for the Oxford AstraZeneca one, which we haven't got. Mm-hmm. And they looked at what happened. And whilst the trial was reported on showing a benefit, when they looked at the data, they found that they had vaccinated people who already were carriers, they were incubating it themselves. So that made the figures look worse than they really were. But if you waited for that incubation period to finish and then saw how many people had been protected, 89 to 90% of people were protected by the first dose. So as we roll out our first dose, and this is with the JCVI's recommendation, go for the most vulnerable first, because we want to save lives, we want to get them on an age cohort, and that was the strategy that was written just on New Year's Day, I think. Other people were doing things, I was writing the strategy. But that was the JCVI recommendations, and that was what we followed, and that was the nursing homes, that was the people 85, 80, 70 and over, and that's what we've been carrying out. And I think there's been heroic work done in the GHA. I know a lot of people have put in a lot of effort, and we know who they are. People like Dr. Rowell, the ministers work ceaselessly as well. There's Professor Cummings has done a huge amount of work as well in assisting us. So it's been an all hands on deck kind of exercise, and the sooner we've done it, the better and the safer it has been for others. I know there's been a bit of confusion about needing 2 doses. We must remember that 100% protection is not possible. There's no vaccine on earth that delivers you 100% protection. So we're talking about the difference between 89 and 95%. The biggest thing to worry about, and the concern I have, is the same concern we have when we have seatbelts. It makes you feel a little bit more safer, so you drive faster. And that's part of the difficulty that I think I have to get across to people. Just because you've been vaccinated doesn't mean that you can't pass it on to someone else. I'm wearing a mask. I've been vaccinated twice. And as I said before, I've also had the disease. So I think I've had plenty of exposure to it, and I should be immune. But what I can't tell you is if it's the virus is sitting in my mouth, so when I'm speaking or shouting or whatever, I might be passing it on to someone. What I can't tell you is whether you or I or anyone has got that immunity or not, because even 95% means 1 in 20 people are not protected. They may believe they're protected, but they're not protected. So if, with my inadvertent spreading of the virus to someone who believes they're immune and they're not, that's why we have to do the social distancing and the mask wearing so far. What we plan to do, and I think a state as small as ourselves, I think it's possible, is we can rapidly gather information about what happens to people who are immune and how often they carry it. So we're continuing to review, we're continuing to do swabbing, we're continuing to carry out the same procedures as before, but for a short period of time. If we assess, and research is now coming in, that the risks do go down, but they're not extremely, they're not eliminated in their entirety, then we can manage, I think we can manage that risk. What I'm wanting for this population is a high uptake here of vaccination. And I think there's a significant pent-up demand, so that's a really good sign.
So an impressive 17,000 vaccines by the end of tonight in 3.5 weeks. What is the total number that you're expecting to have to administer?
Well, we aspire to be able to administer vaccines to everyone in the population who want it. And remember that we are dependent on the UK government providing us with the vaccine. We're of course extremely grateful to the UK government for both the number of vaccines that they've provided us with, as well as the speed which they've delivered the vaccine to us. If you look at it, since we started the programme, we've had a seamless, continuous supply of vaccine, which means that our programme has been able to continue. There's always a day off per week so that staff are able to rest, because they are vaccinating continuously throughout the day. So we're able to have that day off. Maybe the last time that we had a day off was the day before the new consignment of vaccines arrived, because we had literally administered all the vaccines, so that was a good day to take a break. So as vaccines continue to arrive, we will continue to vaccinate, and we will continue to vaccinate at this rate and at this speed. From our part, certainly, from the GHA's point of view, the quicker that we can do this, the quicker we can return to normal. And of course, it's always about safeguarding not only the population health, but really it's about admission into hospital, because we want to avoid the pressure that a high number of positive cases places on the hospital.
So in terms of identifying who needs the vaccine, what do you go off? I mean, do you go off GHA card holders, or do you go off another list?
No, we go off almost like an amalgamation of different sources of information. Clearly, the GHA keeps a list of all the patients who are registered with the GHA, and of course, there are people who live in our community that are not registered. So, and that's essentially a gap. And of course, a vaccination program is not necessarily about the individual only. A vaccination program is also about the population, the community, and protecting the community as a whole. So we will use an amalgamation of the GHA, we'll use an amalgamation of other government departments who keep information about people who are registered as living and resident in Gibraltar and are here actively.
And what sort of number are we looking at? Because we haven't had a census in a while.
Yes.
Are we thinking that there are approximately 32,000 people before, obviously you need to then discount children or anybody certainly under the age of 16 who's
Yes.
not going to receive the vaccine,
Yep.
but also then add up to 15,000 cross-frontier workers. I mean, not all of them are eligible, but there's a significant number of them who would be.
Yes, I mean, I'll be reluctant to give an exact figure because depending on the source of that information, as I said, the GHA information, for example, is those people who have registered with the GHA for healthcare. That doesn't necessarily mean that that is the definitive list, and there are people here who live in Gibraltar who may not have so far registered or have required healthcare at all, or it may not be something that they've just got around to doing as yet. The way to think of this in terms of those numbers is, you're right, we extract the under 16s at the moment anyway, because the vaccine is not licensed for those, and they have amazing, strong immune systems. But we also have to count the people who come in and work, who live in Spain and come and work in Gibraltar, for the main reason that they spend a significant proportion of their lives and their days in Gibraltar. Therefore, they constitute part of our community. A lot of them also work in frontline services. They work in retail. They work in the catering services.
It's duty bound on us to congratulate the government, of course, the British government, the Ministry of Defence, all the nurses that are delivering the jabs into people's arms so that we can get as much coverage of the vaccination to our community as possible, to our elderly and to our old people and the rest of our community. And now with the hope of the second jab, that we can now receive full immunity from this terrible virus and the clear loss of life that we've endured and the pain and suffering to many people in our community. But insofar as the concerns about the vaccination programme, we've heard stories amongst the community and reports being received that the priority may not be quite as it has been illustrated previously. And therefore, I think we're asking the government to expand on how it is delivering the first jab into the arms of people and now how they're going to roll out the second. So I think it's important that people have that reassurance. And I know the website sets out who is prioritised, but we're hearing a number of issues regarding who should be on that list, and people may be being escalated above that list. It may be for innocent reasons, of course, and I can't say that anything it's some bad faith that anything's going wrong here, but it would be important for the government to clarify how we're going to complete this process amongst the rest of the population and how it will be followed through to the second jab.
I'm interested in the new category which was created this week, students, first 16 to 18-year-olds in Gibraltar, schools and colleges, and then students returning to universities also now added. What was the basis for that decision?
We've included the 16 to 18-year-olds and the university students primarily because the cut-off being the 16 for the vaccine, but we also, while they have essentially the strongest immune systems, they also will have lifestyles which will include much more mixing. Younger people tend to mix more. They'll tend to mix within households more. They have closer contact perhaps in a school, in a university. And so we are then trying to break that transmission in that group where transmission may be greater, and it also is significantly harder to maintain social distance. And while we do talk about Operation Freedom and this lifting of the restrictions, at this moment, while we are giving the vaccine, we are still in the early days in terms of understanding the impact that will have in terms of lifting our restrictions. So at the moment, it's not just simply a case of just giving that particular group arbitrarily. We're giving that because it's harder to maintain in those groups some of those social distancing measures that we would like to maintain, and therefore spread is increased. If you have a strong immune system, you are more likely to be asymptomatic, which means you're more likely to spread it to somebody else.
The interesting thing about it from a sort of detached perspective is that the JCVI does not make an allowance for students, does it? It doesn't have students at the level of prioritization that you have given students.
Yes.
So you have deviated from that list.
Absolutely. So of course, the JCVI is a guideline. We use that guideline as best we can to create some form of structure, and it's worked very, very well for us. But we are not the UK. We are not another country using a different guideline. We are our own community, and we work within the dynamics of that community. And we are very, very aware that unlike perhaps the UK, we have much more multi-generational households with young people, with students, with returning university students, who, for example, a returning university student who goes to the UK, for example, and will do their university degree and will come back at Easter next or summer, wherever, they come from somewhere essentially unknown. I know it's the UK, but in terms of community levels of the infection, we have to assume we don't really know. And they are essentially, therefore, a source potentially of bringing the virus back into our community. So we have to protect them as well. So the deviation is there to suit the needs of our community specifically. And of course, I think all along, our history has shown in the last 12 months that we have followed guidelines, we've used guidelines as a general structure, but we've always done it for our community and our community only. And I think in that sense, we've been very successful.
We're talking about a cohort who's aged 16 to early 20s. The chances of them suffering significant consequences as a result of catching coronavirus, developing the Covid-19 disease, are considerably less than an age category who they have now jumped in front of, the 40s to 50s.
Yes. I totally understand that people would kind of second guess that, and essentially there comes that, as we were saying earlier, the younger you are, the less those consequences are. But by the same vein, you could argue that this younger generation are more perhaps socially mobile. They are more moving to bigger groups, perhaps. I know that's a bit of a generalization, but they have more contact in multi-generational households or moving between households. So in terms of a balance of risk, the risk to spread is greater, and the ability for us to recommend, say, to the 50 to 60 or the 40 to 50 and those age groups is such that on a balance of risk, the spread is deemed to be greater. And of course, these decisions are not taken lightly or casually. These decisions are made with advice from the JCVI, for example. We would speak to them, we speak to public health, we speak to all of these kind of organisations and say, look, this is what we are considering, what do you think, and how the evidence shows. We've used models from other smaller communities as well, just to see what they're doing, because there's no point in reinventing the wheel. We understand what everybody, and we just felt that the social movement and the potential risk of infection, and therefore what we were saying about protection of the community as a whole, not just the individual, is just as important.
There's two things, I suppose, that spring to mind. Firstly, that the vaccine does not prevent you from carrying the virus. It probably, we hope and think, will act like other vaccines in slowing down the transmission, although not stopping it altogether. So somebody who's had the vaccine could still carry the virus to somebody else.
Yes.
But more importantly, I suppose, the vaccine first and foremost works because it protects the individual.
Yes.
So if you're concerned about individuals in that younger demographic taking the vaccine home and potentially causing harm by spreading it, then the thing to do is to give the vaccine to those people at home who the students could take it to, right?
Well, this is what we were talking about with Operation Freedom. So, of course, when you talk about that term Operation Freedom, what everybody's looking for is a unlocking and release from things like hand gel, washing your hands constantly all the time, wearing a mask, social distancing, all of those things which are reminders that we are still within a pandemic. So what we're essentially saying is that this is still very, very early stages. We don't understand when we can do that. We're aiming essentially for a normal summer. That's essentially where we're aiming. We're not aiming for everybody to take off their mask by next week, but we're aiming for perhaps a normal summer where we can get back to some of those restrictions. So we have to then apply those kind of measures to the different sections of the community so that we can essentially say which are the levels of all sections of the community who we can still essentially guarantee, or not guarantee, but strongly rely on to maintain the preventative measures that they have done all along. And then which of the sections of the community, perhaps you're right, who may be the spreaders because they're inadvertently spreading, but may not, given their close social interactions, may not be able to follow those social restrictions as well. So it is a difficult balance. The risk to those from 70 and those with very significant other medical conditions is still it's there, and the impact if you catch it as an individual is significant. But once we start moving down into the 50s and below, the risk itself of picking it up is low, and albeit that there are exceptions in medicine all the time, the impact on those from sort of 50 and below is relatively small. So it's weighing up risk, and it's not an easy decision. It's a decision based a lot on not only individual but community, something you pointed out. We are a community where we can control the movement and the ingress of the virus and the transmission of that virus around us much better than a lot of bigger countries, clearly. Mm-hmm. So that's why we've taken that decision.
Okay, and when you say we have taken the decision, who ultimately decides the vaccination strategy? Is that you as medical director? Or?
The vaccination strategy, and therefore the vaccination delivery, is ultimately the responsibility of me as the medical director within the GHA. We are the medical organisation who is providing and delivering that. But this is not a unilateral decision made by me alone, clearly, because I'm not trained in public health. I'm not trained specifically in vaccinations. This is a decision that's been made collectively. So a decision made, advice with Public Health England, with Public Health Gibraltar, with organisations in the UK who are delivering vaccinations as well. So this was a collective decision. It was a discussion. It's something that wasn't born out of just an overnight decision. It was a long considered decision based on the specific dynamics of this community, which differs from other communities.
Do you know roughly how many cross-frontier workers you expect to include in the vaccination programme?
We're not sure at this stage. At the moment, the only cross-frontier workers who we have vaccinated are the cross-frontier workers who work in the health and care sector for obvious reasons. It's important that everyone's immunised if we want to achieve that level of protection. You will recall when we announced the priority categories for vaccination, that cross-frontier workers are included in that. They are the last priority, and but it will be cross-frontier workers who meet the criteria in terms of people who work in frontline services. This is about protection for Gibraltar. It's not about whether you live in Gibraltar or not. It's whether you are in Gibraltar and come into contact with people in Gibraltar to the extent that you may pose a risk of spreading COVID.
We understand that the cross-frontier workers, even if they're working front line, if we put aside the GHA and care workers, they're being asked for GHA cards, and some of them don't have GHA cards because even though they pay their social insurance and are fully registered locally, they have never thought that they needed to take healthcare in Gibraltar.
No, in those circumstances, such frontier workers will be given a temporary registration number, temporary GHA number, in order to enable them to take the COVID vaccine. The reason is that we need to ensure that they're in the system so that we have a record of the serial number of the vaccine and what batch number it is, and then we'll obviously issue them with our GHA COVID vaccination card so that they have it for their records. But it's not a question of people being required to register for a GHA card because they're allocated a temporary number. Obviously, unable to do so, then we need to get their details and confirmation of who they are.
So if anybody's watching this that is in that situation, how can they go about obtaining that temporary GHA number?
At the moment, we are not vaccinating that cohort of individuals because they're not in the current priority list. When we do get to those individuals, then we will advertise what the procedure for them is. If at the moment they are being called because they work in the front line in clinical areas, then we will deal with that situation in-house because obviously they are working in the health and care sector.